Okay, hi everyone. I hope you are enjoying the snow day, and it sounds like we are going to have a snow day on tomorrow or Friday as well. So I know everybody is probably excited about a much needed rest. So hopefully you can get some snow play and some. So this one that we were supposed to do this morning, this lecture is on antibiotics and antifungal medications. So I'm just going to go through this, and I'm doing it in this format because I don't have two computers. Normally I have two computers, so I usually do it in the presenter view. I usually just record on the presenter view, but I'm just doing it in my upstairs where I don't have a second monitor hooked up. And so anyways, so I'm sure this will be fine. So the objectives for this lecture is pretty much we want to focus on mechanism of action, the uses of the antibiotics. We want to talk about some drug interactions, adverse effects, contraindications. And then these are basically all the antibiotics that we're going to go over. And then these are the antifungals, although I think there might be, I think I have a slide that has one more, but I never added mechanism of action. I think it's a systemic antifungal. So, but for the most part, these are the antibiotics. And of course, you have the other sheet that has that huge list of medications. So this slide is talking about the chain of infection, and it's basically showing how, as we look through it here, I'm going to try to make it bigger so I can actually see it. But as you look through, the chain can be broken by several different things. So this shows treatment of underlying disease. So if you have a susceptible host, but you can break that chain of infection by maybe giving them an immunization or a vaccine, perhaps, or you can give them a treatment, and it will break that. It'll keep them from passing that virus or that bacteria on. And so this is just giving other options throughout this chain. So if you never introduce these outward pieces like first aid, personal hand washing, personal hygiene, hand washing, then the chain just keeps going. But if you introduce something, some kind of a treatment or prevention mechanism, then these are how the chain of infection can be broken. These are some words, and notice again, I'm highlighting things that I really want you guys to focus on. These are likely going to be areas where I'll pull questions, quiz questions, or possibly exam questions. So antibiotic terminology, this is the terminology to be familiar with. Antibiotics, chemical substances produced by microorganisms that can destroy or suppress the growth of an organism. So and we'll talk more about this, but antibiotics work in basically two ways. They either can kill the bacteria or they can suppress its growth. So that leads us to these words, bacterial cytal and bacteriostatic. Bacteriocytal basically means that it has the ability to kill a bacteria, and bacteriostatic means that it has the ability to inhibit bacterial growth. And then there's resistance, the ability of an organism to resist the effects of anti-infective agents. So we talk about antibiotics being resistant, or bacteria being antibiotic resistant, meaning that they've sort of figured out a way to not be damaged or killed by the antibiotic. They're resistant to that antibiotic. And then the word superinfection, it's antibiotic disturbs the normal microbes in the body and causes another infection. And so we can think of a superinfection like thrush or candida, where you wipe out all the good and the bad bacteria, and then it sets up a perfect environment for something to just go haywire and take over, and you get a superinfection. When are antibiotics necessary? So generally speaking, our bodies keep things in balance, but somebody they can be introduced to a bacteria that the body just can't handle on it very well, or, there is a wound that gets infected and that infection just goes and goes and goes, and then the body just can't handle it. So the invention of antibiotics has saved countless lives of giving people's body the ability to kind of get a hold of a situation. The antibiotic comes in, acts like a great warrior for the body, and then the body's own immune system can kind of finish up the job. And so before we had antibiotics, people died of really simple things, because that bacteria would just grow and grow and grow, and the body was like, I can't handle it, and then it would end up killing the person. Whereas now, the antibiotics can handle a situation before it gets out of control, and then the body's own immune system can finish up the job. Antibiotics for dental use, typically we use them to treat odontogenic or oral facial infections, possibly could still be used prophylaxically against infective endocarditis. We could also give them as a prophylactic to patients that are at risk for infections because of a compromised host defense system, like, compromised immune system. The ADA has on their website that antibiotic prophylaxis prior to dental procedures should be reserved for patients that are at particularly high risk for post-treatment complications. So it shouldn't just be, kind of willy-nilly handed out like candy, that they have to be really thought about, like, this person is at much higher risk. Maybe it's somebody with severe diabetes, or their infection is just crazy and they know that they need to get a handle on it. So releasing the secret weapon. So where did they sort of first officially come about? So antibiotics were used prior to this, but not really knowing. Like, there are things in nature that are naturally antiviral, antibiotic, or antibacterial in nature. And, other cultures have used things knowing that it did something beneficial, but they might not have known the mechanism. But Alexander Fleming was sort of a messy scientist, and in the 1920s, he had left a petri dish open with some staph growing, and there was a certain kind of mold that was clearing out the staph bacteria. And he realized that he repeated this experiment where he contaminated the petri dish with the penicillin mold, basically, and it kept wiping out the staphylococcus bacteria. And he found that he could dilute it by, he could make it a very weak concentration of this mold, this penicillin mold, and it would still kill the bacteria, like, incredibly effectively or efficiently. And so that was really the first discovery of the drug penicillin. So the goal of antibiotics is to kill the bacteria, obviously, but to not kill the host and to not kill innocent bystanders, i.e. good bacteria. Because, you've probably all heard this before, but we're more bacteria than we are even human cells. Like, we have microbes just all around us, in us, and it's part of our microbiome. It's part of our the balance of our existence. And so antibiotics are hopefully going to go in there and target the bad bacteria that's making us sick, and not everything else. So antibiotics versus antiseptics. Antibiotics hopefully will be very selective. They're going to hit a target. They're going to do just what we want them to do, kill a certain bacteria. And then we have antiseptics, which are non-selective, and they just kill everything. So an example of that is like chlorhexidine, bleach, or, Birex is another, or, our, oh my gosh, I was going to say, what do we have in our clinic? It's escaping my brain, but the wipes we use in clinic. So those are just like kill everything, really, disinfect or sterilize the surface of what we're working on. So to get rid of all the little infectious agents. So finding the best target. Ideally, we can find or design a drug that will have a unique target that the bacteria or the virus or the fungus has, but that's not found in humans. So to say that a different way, we want a medication that will only target something that's found in the bacteria, the fungus, the virus, but that thing that we have targeted in those things is not found in a human. So it really won't hurt the human, it just hurts the bacteria. So things like a cell wall versus a cell membrane. Bacteria and viruses have cell walls, human cells have cell membranes. Different ribosomes. Obviously, bacteria, viruses, fungus, they are going to have different ribosomes than human cells. And then their DNA, targeting their DNA as opposed to human DNA. Bacteriostatic versus bacteriocidal. Bacteriostatic, you can think of static as, like losing the, I don't know if I'm actually thinking of a different word here. I might be just getting someone confused, but you can think of, I think of static as like losing the ability to move around or do what you want. And so it weakens, it disables, it stops the growth of the bacteria. Bactericidal, you can think of that as just going right in for the heart. Like if you shoot someone in the heart or you shoot someone in the brain, they're likely dead, right? But if you shoot them in the arm or the leg, they may not die. It might just slow them down. So you can think of the same thing with different types of bacteria. If it's bacteriostatic, it might do something to weaken it and slow it down, and eventually your body might take over and do the rest of the job, or it might weaken it so much that eventually it dies eventually. But bactericidal is like a kill shot. It goes right to the DNA, most likely, or it bursts the cell wall and it kills the bacteria right away. So the end result of hitting the target. So for cell walls, it's the loss of the structure, like everything that matters in a bacteria or a virus is inside the cell wall. If it doesn't have its cell wall, it's not going to be protected and it's not going to survive. So if you destroy the cell wall, then that will lead to the bacteria or the virus's death. Examples of bactericidal antibiotics are the penicillins or the cephalosporins. Different ribosomes. So certain antibiotics will inhibit the protein synthesis, and that will lead to they cannot make new cell products. So that's going to slow down its growth, slow down its movement. So that's bacteriostatic. And examples of antibiotics that are bacteriostatic are tetracyclines, some of the macrolides, or clindamycin. And then there are antibiotics that go right for the DNA or the RNA. That would be dysregulation or destruction of the bacteria or the virus or the fungus, and that equals death, or you could call that a bactericidal antibiotic. Examples of that are fluoroquinolones or metronidazole. So you guys have talked about this. I know in perio, I saw the gram negative, gram positive writing up on those big white sheets, the whiteboards that you had around the room. So this is just sort of a review. But bacteria has the distinguishing characteristics like the various shapes. You have the cocci or the I feel like that's, I don't remember how to pronounce that. My brain's like having a moment. But anyways, the little rods or the round ones or all the little things that make them wiggle around and move around, but they have different shapes. They grow in different environments, either anaerobic or aerobic. They move a lot or they don't move very much. So there's all of these high or low oxygen. So they just all kind of thrive in various environments. And then you have the gram negative, and gram-positive. And just to remind you, the gram-negative has the pink stain. And I always think about it, there's some more that's written here about it. You're not going to be tested on this specifically. You don't have to remember it, but I always think about it because it has the lipopolysaccharide layer. So I think about it as like an extra shell, so it doesn't hold on to the stain as well. That's just kind of how my brain works. And I don't even know if that's 100% true, but that's just how I remember that the gram-negative is pink. And then the gram-positive is more purple, and it doesn't have that outer membrane. So I just think it just soaks up the purple stain better, and so it stays purple. And like I said, I don't even know if that's 100% factual, but that's just how I remember how one looks and one doesn't. And I'm not going to test you on that anyway. So that's just some background information. You all already took microbiology, and so we don't have to test on that. So with the cell wall, there are specific antibiotics called beta-lactam antibiotics, and it's a specific family of antibiotics, and that includes penicillins and the cephalosporins, and these are just their kind of chemical structures. Beta-lactam antibiotics work by destroying the bacterial cell wall. Penicillins and cephalosporins both have beta-lactam rings and work in this fashion. So those specific antibiotics just use that mechanism of action to kill the bacteria. So beta-lactam antibiotics kill bacteria that are surrounded by a cell wall. The bacteria builds cell walls by linking molecules together, and beta-lactams block this process. So the beta-lactams make it so these particular bacteria cannot build their wall. So, and if a bacteria doesn't have a wall, all the special stuff inside, the DNA and everything like that, the protein synthesis and all these the ribosomes, they can't function. They don't have a house to cook in, sort of thing. And so that will eventually lead to the bacteria being killed. So without the support from a cell wall, pressure inside the cell becomes too much and the membrane bursts. So for penicillins, these are some of the drugs in the penicillin family. We have penicillin V, and there are a lot that are written in different ways. If you look up penicillin, you'll see different drugs that have been traded, trade names for different drugs, but this is just what I have here. So you have penicillin V, PenVK is one trade name. Penicillin V is the generic. You have amoxicillin as a generic. As brand or trade, you have Amoxil and Trimox. And then you have another one, you have amoxicillin plus calvonic acid or calvolinate, and that makes a brand drug that's called Augmented. And so those are under the penicillins. And then for the cephalosporins, you just have to remember Cefalexin or Keflex is the brand. And these all work, they're all considered beta-lactam antibiotics, and they work by preventing the bacteria from building up a cell wall. So for some more information, indications and common uses, for penicillin, it is a narrow spectrum antibiotic. It's used most often for strep infections such as strep throat, pneumonia, or ear infection, otitis media. Amoxicillin is another one, and it's a little bit more of a broader spectrum, and it can be used for tonsillitis, pharyngitis, endocarditis, that would be infective endocarditis, or odontogenic infections. So amoxicillin is very common if someone does not have a penicillin allergy and they need to have a pre-medication before a dental cleaning, which is becoming more and more rare. Less and less patients will need an antibiotic before a dental cleaning or before a surgery or something like that. But if they don't have a penicillin allergy, very, very often they are given 2 grams of amoxicillin. And then for augmentin, this is a much broader antibiotic, and it can be given for expanded UTIs or complicated infections. So basically, if something's not responding or is a worse infection, they might be given the augmentin. Issues with the penicillins: drug interaction, decreased effectiveness of oral contraceptives. So that's important to note. Possible decreased efficacy if given with tetracycline. I'm not sure why they would be given those two different antibiotics, but anyways, increased toxicity of methotrexate and increases the effects of warfarin. You are going to notice a theme with there's a lot of interaction between warfarin or Coumadin and antibiotics. So there is quite a bit of interaction. That's sort of a repetitive theme you might see. On top of that, common adverse drug reactions, you will also see a common theme of GI issues and yeast infections. Contraindications would be a penicillin allergy. So if somebody has a penicillin allergy, they of course cannot have amoxicillin. And also it's likely that the doctor is not going to want to prescribe them cephalosporin because there is an increased chance of having an allergic reaction to a cephalosporin if you have a penicillin allergy. They're kind of cousins. So the cephalosporin antibiotics or the ceflexin or the Keflex, common uses for that: bacterial endocarditis. It says here it's an alternative to amoxicillin, but honestly, I don't even know why I highlighted that, to be honest, because Cipro is another one that actually might be given, or clindamycin actually. Clindamycin is one that might be given, especially if they have an allergy to amoxicillin. They're probably, I would think, more likely they would be given clindamycin, but and then they could also be, Keflex could also be used for a UTI or for a soft tissue infection. Some complications with Keflex or the cephalosporin antibiotics. Again, here's warfarin, may increase the effects of warfarin, GI issues, including nausea, vomiting, diarrhea. Here's yeast infections, rash. These are all kind of repeated themes with antibiotics. Skin rashes, GI issues, yeast infections. Use caution with penicillin allergies. And of course, if they've ever had an allergic reaction to a cephalosporin, you would never want to give it to them again. There can be a cross allergenicity between penicillins and cephalosporins, 10% cross hypersensitivity. So they're at a higher risk of being allergic to a Keflex than if they're allergic to amoxicillin or penicillin allergy. If they just have a mild rash, it's usually okay, but this is all up to the doctor. This is just sort of nothing that we would probably have to worry about, although it is good to know. Severe reactions, of course, you would not use any probably beta-lactam antibiotics such as penicillins or cephalosporins. So I inserted the endocarditis information here just because it's close to the medications that most oftentimes are used for patients who need a prophylactic antibiotic. Adult prophylactic would be used for dental or oral procedures, cleaning, surgeries, and a standard regimen, your most common regimen, is amoxicillin 2 grams by mouth 1 hour before the procedure. It can also be given like right when you're about to do the procedure, or it can even be given after if the person forgot. But this is your most common, and like I said, it's becoming more and more rare. Clindamycin, if there's a true allergy, penicillin allergy, and they can't take cephalosporin either, then you would give them either clindamycin 600 milligrams by mouth 1 hour before, or azithromycin 500 milligrams by mouth 1 hour before. And if they can take Keflex, then you give them a cephalosporin 2 grams by mouth 1 hour before. And then the question, which medication could be used if a patient has a history of anaphylaxis when taking cephalosporins? Then that would be either the clindamycin or the azithromycin. What patients would need prophylaxis? Well, I highlighted here, this is something that was taken out of a pretty current article. So this is pretty up to date. You can go to this link and see if they've updated it anymore, but this is pretty much what I think the standard still is, even today. But if you notice in each one of these bullet points, valve, 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 valve. So just know that if you have a patient with anything with their heart valves, replacement, damage, anything like that, that's the biggest red flag for prophylactic antibiotics. History of infective endocarditis as well. But a prosthetic cardiac valve, including a transcatheter implanted prosthesis or homographs, prosthetic material used for cardiac valve repair such as annuloplasty rings and cords, a cardiac transplant with valve regurgitation due to the structurally abnormal valve. So you can see there's just this recurrent theme. Following congenital present at birth heart disease, so if they had a major congenital defect, unrepaired cyanotic congenital heart disease, including palliative shunt and conduit, any repaired congenital heart defect with residual shunts or valvular regurgitation. So valves, congenital abnormalities, history of IE, things like that. So those are your major red flags for why somebody would definitely still need pre-medication before cleaning or oral surgery. And then this is just an even more kind of simplified one from the American Heart Association. Patients with artificial heart valve, history of IE, patients having serious heart conditions present from birth. So various congenital issues. This is probably fairly close to obsolete. However, I kind of like this decision tree, so I left it in there. Almost no patients with artificial hips or knees or anything would you need to give a pre-medication to. However, there probably are some exceptions out there in the world. But this is a decision tree that I just thought was kind of neat. And so it says, if I can read it, so tiny, implant patient with a planned dental work. Yes. Okay. So you're going to go, and that's a yes. So what's the next question? Invasive dental procedure. Is it very invasive? Let's just say yes, it's very invasive. So we're going to go up to the yes. Severe immunocompromised. Yes, let's say yes, they are very severely immunocompromised. Have they had a history of an infection in their joint requiring an operation? So requiring them to go back in and clean something up. Let's say no. So then the answer for whether or not they would need an antibiotic is rarely appropriate. In that case, what I would do, if you had a very high risk patient, but they've never had an actual infection in a joint that put them back into surgery, then basically what I would do is I would talk to the doctor and I would call their orthopedic surgeon and I would just ask them, do you want them to be pre-medicated? And I would leave it in their court. Let them make the decision if they want their patient pre-medicated. Okay, let's move on to some more antibiotic drugs. So now we are going to talk about class of antibiotic drugs that are called protein synthesis inhibitors. Now, just by the name protein synthesis inhibitors, what you know about these drugs is that they are bacterial static because they are inhibiting protein synthesis. So they are bacteriostatic. We're going to be talking about macrolides, which include erythromycin base or E-mycin, azithromycin, Zithromax, and then lincomycins, which include clindamycin or cliocin, and then tetracyclines, which is tetracycline HCl, And then you have whatever these two different drugs. These are two separate drugs. And then doxycycline, vibromycin, and then minocycline HCl, minicin. I also think I have a slide coming down a little bit later that talks about Periostat, which is a doxycycline low dose that is prescribed for perio. So the first one, macrolides, that is your erythromycin, azithromycin. And the mechanism of action here is that it binds to the 50S ribosomal subunit to inhibit the protein synthesis. So it is binding to a ribosomal subunit, and it therefore is inhibiting the protein synthesis. That makes this medication a bacteriostatic medication. The common uses for the macrolides are upper respiratory infections, including bronchitis, pneumonia, sinusitis, etc. Could be used for acne, uncomplicated skin infections, STDs such as chlamydia, mycobacterial infections such as tuberculosis. And like we said earlier, that's erythromycin and azithromycin. Drug interactions, here again, you can see warfarin. Many, what does this say? Erythromycin. So many of the drug reactions are more common in erythromycin than azithromycin. But you can see there's drug reactions for warfarin, antiarrhythmic drugs, digoxin, cholesterol medicines. What do all of these have in common? Warfarin, antiarrhythmic, digoxin, cholesterol. What do all those have in common? The answer for that, and I know it's not here anywhere, but all of those drugs are very likely given to people with heart disease, right? Cardiovascular disease, and then antidepressant as well. So erythromycin tends to interact more, but lots of drug interaction. Adverse drug reactions, again, you see GI. Again, erythromycin is more than azithromycin. And then rash or cardiac arrhythmias. Contraindications, if there is an allergy to the macrolide, you want to use with caution with certain drugs. And then patients who have myasthenia gravis, which is an autoimmune disorder, they have to be cautious being prescribed erythromycin or azithromycin. Okay, lincomycin or the clindamycin cliacin. So common use, bacterial endocarditis for the prophylaxis, especially if they're allergic to penicillin, soft tissue infection, bone infection, or any anaerobic infections. And again, we're talking about bacteriostatic drugs. Very few interactions with clindamycin or cliacin, mostly insignificant. Adverse drug reactions, diarrhea, abdominal pain. There you go, your GI things again. Clostridium difficile diarrhea. So if it wipes out a lot of their good bacteria, they can have sort of like chronic diarrhea, and which can be pretty awful. Rash, yeast infection. Contraindications would be allergy, pseudomembranous colitis, ulcerative colitis, overgrowth of dangerous bacteria. So if they have serious GI issues, they probably should not be given a cliacin. Tetracycline mechanism of action, it binds to the 30S subunit of the ribosomes to inhibit protein synthesis, similar to erythro and azithromycin, although instead of 50S subunit, it's the 30S subunit. Common uses for tetracycline, soft tissue infection, and it can also be used to treat MRSA, or methicillin-resistant Staphylococcus aureus, MRSA. Respiratory infection, such as pneumonia and bronchitis, Lyme disease, or STD, such as chlamydia. And would this one be cytal or static? And the correct answer is static. Tetracycline has drug interactions, some over-the-counter supplements, or I don't know how else someone would get aluminum, but anyways, calcium, magnesium, aluminum, iron, Warfarin again. See that warfarin? So that you can pretty much guess that warfarin might come up as a quiz question. Adverse drug reactions, GI upset, photosensitivity. So this is a new one for tetracyclines, photosensitivity. So sunburn easily, rash, yeast infection, contraindications, allergy, pregnancy under the age of 8 years old, totally contraindicated. And you can see over here, you might see all these images of these very discolored teeth that are kind of almost gray. That is because tetracycline gets taken up into the teeth as they develop. And if a pregnant woman is given tetracycline, it can stain the baby's teeth because their tooth buds are forming. So whatever teeth are forming in utero, and when they're young, when they're under the age of 8, whatever teeth are still forming can get stained. So the younger they are, the worse. Once they're past the age of tooth development, it's gonna be fine. And there's no way to bleach that out, by the way. People who have tetracycline stain, there's no way to bleach that out. You have to get like crowns or veneers. So it's pretty big deal. There's specialty tetracycline preparations that can be used as adjunct to SRP or scaling and root planing. Doxycycline 20 milligrams or Periostat. It's also just called, doxycycline low dose, and it's a pill, and it's actually in such a low dose that it's not considered an antibiotic. But what it does is it actually has a positive effect on the breakdown of collagen. And so that's why it actually works to help with periodontal disease. So some doctors prescribe doxycycline or Periostat to their perio patients. There's also localized therapeutics, so things like minocycline, spheres, Arestin, Atrodox, or it's also another doxycycline. These, there was a lot of excitement about these in the beginning, but these really are not proving to be as great as I think people hoped. And they're very expensive. So you will have the opportunity to utilize them in our clinic, but out in the world, and you'll learn more about these in perio, out in the world, those are incredibly expensive. Insurance doesn't cover it. And there's just not as great robust evidence that it actually does what we hope it would do. So, okay, now the quinolones or fluoroquinolones. These are your Cipro, ciprofloxacin, levofloxacin or Levaquin, and trovaloxacin or Trovan. The uses for these could be urinary tract infections, upper respiratory infections, pneumonia, or even perhaps chronic periodontitis. Someone might be prescribed them. And they are not typical antibiotic. They are actually synthetic. But they are considered a broad spectrum antimicrobial, and we just sort of use them as antibiotics. Fluoroquinolones, the mechanism of action is that it interferes with the DNA of bacteria, so that means that it is bacterial cytal. Adverse drug reactions, again, we have some phototoxicity, so probably not just sensitivity, but maybe can get sick if you're out in the sun. So patients probably have to be careful with that. Dizziness, headache, cartilage damage. Again, my goodness, we see warfarin, caffeine, dairy products, iron, and antacid drug interaction. Metronidazole or Flagyl is another medication, and it interferes again with the DNA. That means it's bacterial cytal. Common uses for Flagyl are for anaerobic infections, necrotizing gingivitis, peri-implantitis or implant infections, H. pylori eradication. H. pylori causes it's a bacteria that gets out of hand in the gut and causes ulcers in the GI. So Flagyl can be used to help with ulcers or H. pylori, and then protozoal infections as well. So little parasites. For metronidazole, there is a very significant interaction with alcohol, and it is so strong that even after you've discontinued the medication for a couple days, there can still be nausea, dizziness, and headaches if alcohol is consumed. So if a patient is on my metronidazole, they should avoid alcohol 3 days after they have discontinued the use of metronidazole, because they can still get these effects. Again, we see drug interaction of warfarin, adverse drug reactions, nausea, epigastric discomfort, metallic taste, furring of the tongue, furry tongue, headache, dizziness, peripheral neuropathy. Those sound like some not very fun adverse reactions. Contraindications, allergy, pregnancy. Obviously there's some tetragenic adverse effects toward the fetus, so nothing in the first trimester. Strong caution with alcohol use. So antibiotic conclusion, there are many different classes of antibiotics, different target sites, different bugs are killed. There's an inhibition versus the killing, so the static versus the cytal. We want to use antibiotics wisely. We don't want to overuse them so that they are available for us in the future. And so we don't develop that antibacterial resistance. And this is just a great slide. It kind of synthesizes, there's lots of different, some medications we haven't talked about, but it sort of sums up some of these medications. So I just liked it. You're not going to be tested on this, but I just liked how it talks about protein synthesis, the 50S inhibitors, erythromycin, and then tetracycline is the 30S. So it just kind of reviews some of the stuff we're talking about. This is just a suggestion for how to study for some of this using a chart like this. And then just a few slides here for antifungals. Basically, if your immune system is weak, the fungus in your system can grow out of hand, or if you take strong antibiotics, the fungus can grow out of hand. And that's what that slide is indicating. For antifungals, we have the azoles, the micanozoles like monostat, or clotrimozoles, the Miselex. We also have the Polonese, which is like nystatin, or the mycostatin. The azoles are static, so they sort of slow it down. They block the ergosterol synthesis. Ergosterol, I don't think I'm pronouncing that right. And then the nystatins, they bind to the ergosterol in the cell membrane, and they cause leakage, which leads to death. So azoles are static. Nystatin is cytal, or leads to death for the fungus. And then, like the other slide said, for the azoles, we have the clotrimazole, or the Miselex. We have the miconazole, or the monostat. The common uses are oral and vaginal candidus. So oral candidus would be thrush. Fungal skin infections. Drug interaction. There's a drug interaction with cyclosporin, and again, warfarin. My goodness, warfarin reacts with everything. And then adverse drug reactions, minimal systemic absorption, local irritation, contraindication if there is an allergy. The nystatin, or the mycostatin, the common use is oral and cutaneous fungal infections. There's not really very much drug interaction. There can be nausea, vomiting, diarrhea, local irritation, or if somebody is allergic to it, they should not be using it. And then I did put the diflucan, or the fluconazole. That's a systemic antifungal that's used for systemic yeast, or yeast infections, or other systemic yeast. So there's not a slide on that particularly, but just being aware that that's what diflucan is used for. And that's the last slide. So I hope you all have a great day, and I will talk to you guys soon. I'll see you soon.